me tell you about the line of weight transmission in upper limbs. This means like when you are carrying weight in your hands, maybe on one side, so that weight has to be shared to the axial skeleton, right? So to maintain your balance, and the line of gravity should be passing between both your lower limbs, so as to make you in a stable gait. So can you think of, like, if I ask, like, if a person is like carrying let's say 10 kg weight in his right hand and is walking like that, so will his, like, the spine, will it be like convex on the right side or concave on the right side where there's lifting weight around 10 kg? So what will be the curvature of the spine? Are you guessing what I'm asking? Like, will this be person carrying weight like this? Let's say it's like a weight here, and so will the spine be like this or like this? What will be the position of the spine if he is carrying weight on the right side, on his right hand? Will it be like bending concave to the right side, or will it be like convex to the right side? Think about it. So you know that to maintain your steady gait, your line of gravity should pass through the median plane. So that means to carry and walk along with the weight, this will be the exact position. You actually carry load, like if it's 10 kg, normally, like if it's say like 60 kg of weight of a person is, so 30 and 30 kg is like shared equally to both the lower limbs. Remember, the sacrum is like a V-shaped bone, and through that sacrum to the sacroiliac joint, the weight is shared to both the lower limbs. So if a person is 60, 30, 30 goes to both the lower limbs, and your line of weight transmission passes through the center of the spine. But if you are taking additional 10 kg on the right side, so you actually, the line of gravity is going to shift on the right side. So to bring it back into the median plane, you actually need to tilt your spine such that there is a convexity on the right side, and you actually lift it like this. If you're still going to you will fall down, or you will not be able to walk if it's concave on that side. Got it? So this is the actual position where you carry load in your hand. So that the line of gravity, this is like the line of gravity should stay in the median plane. This is line of gravity. So talking about this line of gravity now, how actually this weight, let's say it's of 10 kg, how is it being going here? How is it, this weight is being shared to the axial skeleton? Now look here. This you're seeing is the right hand, and in this right hand, let's say there's this person carrying a weight or a carry bag in his hand like this, and this carry bag, it's around 10 kg. So this weight has to be shared to the axial skeleton. It's like here, you have this spine here. This is the spine. Remember, now here it will be the sacrum. And to the sacrum, there is this pelvic girdle on the side. So weight actually gets shared to both the lower limbs, right? So front here you have is the manubrium. Like here you have is the, this as the manubrium. Got it now? And to this manubrium, both the sides you have is the clavicle, right? And below to that is this first rib, like this. And here you have is the scapula, this acromion process. This acromion process, like this. And here you have is the glenoid facet, and this, let's say, is the scapula. And here you have is the coracoid process of the scapula. And here you have is it's the humerus, the capitulum and trochlear, like this, humerus. And here you have is the radius. Remember, the radial styloid process is more distal, like this. And here you have is the ulna with the proximal styloid process, which is lower down tapering bone. And here you have is the carpus, made up of 8 arthropods. Got it? So when you are lifting a weight, that weight is first initially taken up by the carpus, the manus and the carpus. So weight lies actually initially it is shared to the carpus. So subsequently, initially the weight is shared to the carpus. Carpus is the wrist made up of all the carpal bones. So weight is taken up by the carpus initially. And then from carpus, this weight will be shared to radius. Why? Because the wrist joint is made up of 4 bones. The lower, the distal end of radius articulates with scaphoid and lunate, as well as triquetral is a part of this joint. Although ulna does not articulate with triquetral because of the intra-articular disc that separates the ulna from participating in this joint. So there are 4 bones. So weight is actually shared to the radiocarpal joint, right? So from there, the weight is shared to the lower end of the radius. So this is radius. Remember the lower end of radius is the weight bearing end, because ulna does not participate in the wrist joint. Then from radius, this is radio-humeral joint, and the radio-humeral joint is such that you have a hemispherical capitulum of the humerus, and there is the discoid shaped head of the radius. So that joint here formed between this radio-humeral joint is a pivot, is a sort of ball and socket joint. The socket being is a very shallow sort of socket, the upper end of the radius, and the capitulum acting as a head. And that's why there is this osteofibrous ring here, right, surrounding to the neck of radius, which encircles this head of radius. And in the early childhood, let's say less than 10 years of age, there is no gripping of this fibrous ring, osteofibrous ring surrounding to the head and neck of radius. So in early childhood days, you must have read in the books that when you lift a child like 6-7 years, like with both his upper limbs, you lift him up and you just make him swing like this. So there are chances of dislocation of this radio-humeral joint, and that's called pulled elbow. Pulled elbow. So reason being that this fibrous ring encircling this head that is not gripped below. Got it? So in the early childhood, this is what I'm talking is the head of radius, right? And this is the tubercle, and here you have is the ulna, right? So ulna is superiorly have this coronoid process, and then you have this auricular process, right? This is like ulna. So this ring here, which encircles the head of radius like this is actually clamping this, and it also is participating in the form of superior radioulnar joint, which is a pivotal variety of joints. So it also provides this rotation of radius to the ulna and causing this supination pronation movement. Of course, there is like distal and intermediate radioulnar joint also participating in this supination pronation movements. Later on, so that's why it gets easily dislodged from this joint. But around after 10 years of life, this gets shrink, constricted below. So when it gets constricted like this below, so it grips this neck of radius, so it doesn't get easily dislodged. So in adults, it's not a problem. Anyway, so that was about the pulled elbow. This is about pulled elbow thing. Now have you seen that upper end of this is a notch. It's a notch thing, and that notch is called the trochlear notch, which fits in with this trochlea of the humerus. And remember that this trochlea had a medial and a lateral flange. The medial flange is dipping down more. This medial flange of trochlea is around, is around 6 millimeter more dipping down. It's more in length. So this is the exact reason why your ulna deviates laterally, causing the formation of carrying angle. And that actually, this medial flange of the trochlea also prevents the collapse of this carrying angle. Got it? One other point you get from this is that this medial flange of trochlea is also helping you for sexual dimorphism of humerus. If you have two humerus, let's say from male and female cadavers, and you have to ask decide which one is of females. So just look at the medial flange of the trochlea. The medial flange of the trochlea will be more in case of female humerus because the carrying angle is more in females. So this also, this point here also helps in this is more in case of females. So medial flange of the trochlea helps in sexual dimorphism of humerus. This helps in identifying or differentiating between male and female humerus. Now, because weight now you be taught about this pulled elbow. So that means weight cannot be shared directly from radius to humerus because it gets dislodged. It's not a strong joint. Remember, radio-humeral joint in an extended elbow is not a stable joint. So weight, there is this interosseous membrane binding the two bones, and it is also called a type of joint called syndesmosis, where the two bones are held together with the help of a ligament binding. It's an interosseous membrane. Now, and it has a typical direction. Remember, the collagen fibers, the direction of fibers in this interosseous membrane between radius and ulna, they're directed downwards and medially. Downwards and medially towards the ulna. So, the weight will now be shared from radius to ulna like this. That's why it has a single shear. If it would have been the opposite way, the direction of forward, the weight would have not much been easily shared. So being opposite directed downwards, the weight from radius is shared to the ulna first. And now from ulna, the weight will be shared to humerus. Got it now? So superior end, or you can say proximal end of ulna is being having a notch that is called trochlear notch. Anteriorly it has a smaller process called coronoid process, and superiorly or posteriorly it has this a bigger process called the olecranon process. So when you are in an extended elbow, this olecranon process actually moves behind and goes into a fossa behind in the lower end of the humerus, that's called olecranon fossa. So when olecranon process goes within this olecranon fossa, the joint is actually this type of joint. This is a very stable joint. So humero-ulnar joint is a very stable joint in an extended elbow. You may not even like 10, maybe 20, maybe 30, maybe 50 kg or more. You can easily lift that weight because of this humero-ulnar joint having this type of notching. So this is a very stable joint in an extended elbow. But think about the flexed elbow. Now if there is a flexion at 90 degrees, remember as I was telling that this ulna goes behind and goes inside the olecranon fossa. But when you are like, let's imagine you're pushing a big vehicle like a truck or a bus, you're giving push from behind. So that time ulna, we are flexing it at 90 degrees. Now this olecranon process is out. It's moved outside the olecranon fossa. So in a 90-degree flexed elbow or even more, there are chances of dislocation of ulna, posterior dislocation of ulna. Because now what prevents posterior dislocation of ulna is a smaller bony process that's called coronoid process. So if the coronoid process of ulna breaks your ulna moves out posteriorly. And by the way, let's for MCQ purpose, let's talk about the four major joints: so shoulder joint, elbow joint, hip joint, knee joint. If it's asked like what's the most common side of dislocation of hip joint? Posterior dislocation. What is the most commonest dislocation of the knee joint? Posterior dislocation. What is the most commonest dislocation of elbow joint? Posterior dislocation. Except shoulder joint. Shoulder joint, the most common side of dislocation is inferior dislocation. There this capsule is deficient inferior and there's a rotator cuff and acromialage and a lot of more protection from anterior, superior and posteriorly, but inferiorly it's lacking protection. So inferior dislocation of shoulder is common, otherwise elbow, hip, knee. Most common dislocation is posterior dislocation, even in case of elbow. But in an extended position, this joint is a very stable joint. So now this weight will share from ulna to humerus. Then this weight from humerus will be shared to this bone called scapula through this joint, glenohumeral joint. This joint is glenohumeral joint or ball and socket joint. So that's why there is a lot of protection, like lots of thick capsule, then there are thick ligaments, and coracohumeral ligament, then there is this rotator cuff muscles also. So all that or preventing this joint, making it sort of stability, although that this joint is not very stable though. Then in case if it's large, ask what is the weight bearing end of ulna? So you have seen it here right now that ulna upper end weight bearing end is the proximal end. Proximal end of ulna is the weight bearing end. In case of radius, it's the lower end which is the weight bearing end. Right? This is the weight bearing end. that's how weight is shared to the scapula. Now how the weight will be shared to clavicle? Remember, there are many ligaments attached to clavicle, but the strongest ligament attached to clavicle is there's a conoid and a trapezoid portion of this ligament. This is called Surractoclavicular Ligament. From coracoid process, it is attached to the lateral inferior surface of the clavicle on the lateral 1/3 inferiorly. So this is Surractoclavicular Ligament. And remember, it has two parts. Sometimes nowadays they give you image based questions and they give a pointer. So out of the two, if they point out one of the two, which will you mark? So remember, this one is the medial and this one is the lateral. C, and remember this conoid, C-N-O-I-D. Conoid part is the medial part, and trapezoid part is the lateral portion of the Surractoclavicular ligament. C for cervical, C for neck. Cervical means neck, the C is closer to the cervical region. Just remember this. So conoid is medial. Okay, so from this Surractoclavicular ligament, it is the strongest ligament attached to clavicle. From here, the weight is from scapula, the weight is now shared to the clavicle in its lateral portion. Now this weight has to be shared ultimately to the axial skeleton. So from here, this weight now will be shared to the axial skeleton through, remember, not through this joint actually. This joint again is not a very stable joint. Okay, sternoclavicular joint is not a very stable joint. So there is something which is providing additional support to the medial and the clavicle, and this is the Costoclavicular ligament. This is the Costoclavicular ligament. This has been asked in your All India exams, NEET PG. So it's this costoclavicular. It was asked like which ligament actually shares the weight from upper limb to the axial skeleton, or which structure even. So you can remember that it is through this costoclavicular ligament that the weight is from upper limb, the weight is shared to the axial skeleton. Okay. Now being shared to the axial skeleton is a sternum, but your weight has to reach the sacrum to be shared to the lower limbs. So from sternum, how will it reach to the axial? It's of course a part of the axial skeleton. Now through the 7 true ribs, remember, there are the 7 true ribs. Through those ribs, now the weight is shared to the dorsal spine, and then through this spine, the weight is shared down to the sacrum, and from sacrum it will get distributed to both the lower limbs. So that was about the line of weight transmission in upper limbs. I hope you've understood it.